I'm going to start with Patrick Johnson.
Good afternoon, everyone. It's always good to see all of you. Patrick Johnson with NAMI, Jefferson County.
Good to have you here, Patrick. Cherish?
This is Cherish Cronmiller, Executive Director of Olympic Community Action Programs, your community action agency for Jefferson and Clallam counties. Welcome, everyone.
All right, that was scintillating.
You asked for it, so you know.
Richard Davies.
Well, I'm a public defender here in town.
And that also was scintillating. Thank you. Adam?
I'm Adam York. I'm a data analyst at Jefferson Healthcare.
Adam, I'm just dying to know where you are, that you've got like this very artistic background.
I just have the lights off and the desk lamp. I'm battling a migraine right now, so just.
Oh, I'm sorry.
Yeah.
If it helps at all, your whole visage is very artful.
Oh, good, but some perks.
Deborah Tillman.
Hi, my name is Deborah Tillman. I'm a fire commissioner for East Jefferson Fire Rescue, and in my off hours, I work as an ARNP. Also a retired fire medic for many years here in Jefferson County.
Thank you for being here. Okay, have I missed anyone? No. Then I am going to go ahead. I've put the meeting packet in the chat, but I'm going to put it up there again. Just so that folks have access to it. I know sometimes the slides look small on the screen, so feel free to open it on your own and follow along if that's helpful. I'm going to share my screen quickly.
And Lori, are you missing anyone? I noticed that the link in my calendar kept saying invalid ID, but when I went into Zoom and used that link, it came up for me. So just FYI, in case anyone else alerts you that they're struggling to get in.
Thank you. And you know, I put the latest Zoom link in the chat as well. Let me just unshare for a second here. Are you guys looking at the
the agenda?
Yeah.
Okay. Hold on one second. I'm going to put that new Zoom link in again. In case anybody is texting you saying, I don't know how to get in, this is the link you want to give them. Like we said, Zoom seems to have its own personal Zoom Mercury retrograde going on right now. Okay, so over to the agenda. Today, we are going to continue our funding discussion that happened last week. Our plan is just to give a high-level overview of the Behavioral Health Consortium's vision, just because that's relevant as we think about how we're spending the money that we have. And then I'm going to turn it over to Lisa Ray Thomas to facilitate the rest of the discussion, funding-wise. I thought it was important to have somebody who knew the group, is invested in all that we do here, but is not actually going to be impacted by which way this money goes, because she lives in Kitsap County. So we'll go through and have each of our funding requesters respond to the questions that came in from the survey that went to the voting members. We asked voting members to give us what questions they needed to have answered so that they could be prepared to vote. So those responses will be given from our two requestors, and then at probably later tonight, I'll send out another email to get the vote from the members to find out how that funding decision will go. And then after that, if we've got time, I've got some additional meeting packet content in there, a legislative update, and a quick overview of what I hope to accomplish at our next meeting. Are there any questions before we get started? Okay. All right. Quickly, I just wanted to anchor everybody that this table, the consortium table, is focused on collaboratively developing and funding a collective, seamless behavioral health system that allows our community members to navigate smoothly to the needed behavioral health services. We started as a 4 voting member organization back in 2018, and we have grown to 11 members now and a really robust ad hoc group that comes and participates and for whom we're very grateful. The work of the folks at this table is funded by a federal HRSA R-Core implementation grant that continues through August 2023. And now I'm going to pass it over to Lisa Ray Thomas, and we'll go from there. Thank you.
Thank you, Lori, so much. And thanks everybody for your time today. I'm guessing we might have a few people trickling in because as Cherish said, they might be going to the old thing. So we welcome them as they come in. And Lori, thank you for giving everybody a high level reminder of the vision and goals of the Behavioral Health Consortium. And we're really inviting all of you as you listen today and respond with any additional questions that you have to keep that vision and the goals in mind. And as a clinical psychologist, I think it's sometimes helpful to call out elephants in rooms if it furthers the conversation. So I do want to acknowledge that in the December meeting, so it was last month, Lori, not last week, time is flying, that you all raised some concerns about the challenges with relationship building and collaboration in developing these proposals. So I just want to acknowledge that that was a concern that was shared and invite you to use the framework of a commitment to the community and the BHC as you listen to the responses from Anya and the CARES team and frame your discussion. So Lori provided the questions that you all submitted to both of the groups so that they could provide thoughtful responses today. They'll each have a few minutes to respond, and I'm going to ask you both, Anya and the CARES team, to summarize at the end how your request aligns with the goals and visions of the BHC. And then we'll have time at the end for questions. And instead of sort of opening it up, I'm going to start with a round robin. So I will invite every member who's here today to follow up with any questions if you want to, or pass if you want to, so that everybody has an opportunity to speak. I know that I often am not comfortable speaking up, but if I'm called on, that's more helpful. So I'm going to use that approach. And I think that is it. So again, thank you so much. And I think we're starting with Anya.
Thank you. So here on the slide, you will see an outline of this question, how my request aligns with the goals and visions of the BHC. So for folks who are new to me or to the consortium, I've been working with the consortium since last spring. My main focus is distributing naloxone and training the community on how to identify signs of an overdose and what overdoses look like, and overdose prevention, as well as how to access different harm reduction services, treatment and intervention services in our community. Everything highlighted in blue are activities that I believe that my project is covering for the grant. Linguistic and cultural efforts to reduce stigma, increase naloxone access and training. I'm supporting the drug take-back events. Since I've been working with the consortium, we've been doing naloxone distribution at the county drug take-backs. I've also been supporting school and community prevention programs by partnering with the Jefferson County Empowered Teens Coalition, specifically focusing my work in South County right now, connecting with the Quilcene Brennan group. I've done 3 events down in Quilcene in the last year, and we're planning more for this year. And improve screening for SUD, OUD, provide referrals to providers, harm reduction, early intervention, treatment, and support. So also when I'm tabling or doing outreach with folks, I'm providing resources to our existing treatment providers in our county, and harm reduction resources that the public health department has their awesome new brochure, information about the Believe in Recovery mobile unit, information about Discovery Bay, and other existing resources that folks might not already know about. On the treatment line, on T4, reducing treatment barriers by being out in the community and talking to folks about what different types of treatment looks like, talking about harm reduction versus abstinence-based programming and how to meet folks where they're at. Improving referrals to providers and harm reduction supplies, early intervention and support, and enabling also like the general community, maybe not folks who are struggling with misuse of substances, but family and caregivers to find access for treatment, their own support, and supporting their loved ones. And then on the recovery line, enabling individuals, families, and caregivers to find access and navigate treatment for SUD, OUD, as well as home services and community-based services and social supports, as well as supporting development of recovery communities, recovery coaches, and recovery community organizations to expand availability and access to recovery support services. So partnering with folks like Abby at Believe in Recovery, Brian at the Recovery Cafe, all of you, please, I'm here for you. So feel free to invite me to an event, or I can come talk to your team. Would love to do more collaboration with folks throughout the BHC. So that's how I believe my request aligns with the goals and visions of the BHC. Should I go on to my budget, or do we go on to?
Yes, please.
Okay,
Thank
so
you. And I'm watching the time for you, Anya.
Awesome, thank you. I know that, yeah, I don't want to take too much time. So this is a draft of what I will be doing with the funds if they're approved. I've bracketed them out into 4 different categories. Trainings, I'm planning to do more community-wide trainings and before the end of the grant in August. I'm also working on collaborating to develop some Zoom webinars to have some more accessible online trainings, naloxone trainings, and like Q&As, potentially partnering. I know Dr. Carlbaum mentioned that he'd be happy to come and do some Q&As, informational meetings. Would love to invite anybody else here in this room who's interested in participating in that. And then also interested in partnering with folks who have lived experiences to come and share their stories. So you'll see there's a stipend to support folks with lived experiences and honor their time. My outreach column, I'm planning to do more design work, more outreach with flyers, social media graphics. The sticker, the naloxone sticker, we'll probably plant more of those because those have been really popular. So working with a local graphic designer to make some attractive outreach materials, budgeting, printing for flyers, brochures, materials for the naloxone kits, marketing, hoping to do more earned media, we're reaching out to the leader, reaching out to the Peninsula Daily News, writing press releases about events, sharing some of the work that we're doing, get earned media that way. If it's appropriate, potentially buying ads to promote events that we're working on. Let's see. And then as far as supplies goes, for the kits that I use, I will be buying, my goal before August is to do 500 kits. So budgeting and buying more materials for the kits. Right now, my naloxone is being distributed through a Department of Health Drug User Health Program grant. So I don't have to budget for that, which is awesome. And then more harm reduction outreach supplies. Part of my goal for this new year is to do more outreach to people with lived experiences. Tomorrow, I'm going to be going out with Ocean and some folks from the Syringe Exchange Program to meet with some unhoused folks and bring supplies. So would like to have more funds to meet the needs of those folks who are impacted. And then last, but certainly not least, I'm proposing a video project, an informational video to highlight all of the awesome work that we've been doing as a coalition over the last 5 years, and specifically highlighting harm reduction resources, information about what harm reduction is, and how folks can find naloxone in our community, find treatment and intervention resources in our community. And if folks want to know more about the video project, on the right there's a link to Whale Heart Productions, and you can click on that to see Gabe from Whale Heart Productions bid. He's done some really awesome videos for the Olympic community of health, and would be really excited to collaborate with him and have something that could, live online and live beyond the BHC and gain more traction. So yeah, that's my budget. How do I know this work is effective? I wanted to respond to some of the questions that I received last month. So I did some research on the University of Washington library website and found some recent studies that support this type of overdose education and naloxone distribution work that I'm doing. Studies have found that in communities that are doing this type of like peer-to-peer grassroots naloxone distribution, it's associated with lower rates of opioid overdose deaths. And that programs that have community education and engagement we're seeing long-term knowledge improvement regarding opioid overdose improvement and participants' attitude toward naloxone, training to participants to safely and effectively manage overdose, and effectively reducing opioid-related mortality. And then putting Dr. Carlbaum back on the spot a little bit, I know that he shared a couple months ago that it seems that the recorded rates of overdose in our county have gone down in the last couple of months, and there is speculation that the 350 naloxone kits that I distributed in the last half of last year might be helping contribute to that. That's all I got for you.
Thank you so much, Anya. So as a reminder, you all submitted questions after the presentations and at the December meeting. And so Anya and the CARES team are responding to those questions in this meeting. So thank you, Anya. And I will invite the CARES team to go next. And I will watch the clock for you. I believe there's 10 minutes. Is that right, Lori? Okay.
Yeah, right. Sorry, I was on mute.
So Chief Black, I don't know who's gonna, or Debbie.
Yeah, I can certainly start off, and then we're certainly not going to be as polished as Anya's great program, great presentation, Anya. But we have a slide deck that we put together, and then Gabby, keep you from going off the rails. And
I'll do my best.
It looks like there's another participant sharing, so I can't share.
I'm leaving that up there because I think Lisa Ray Thomas was going to have folks speak at the outset about how what you were doing sort of aligns with what the BHC's vision and goals are.
Oh yeah, thank you, Lori. So this is a slide that goes over that.
Got it. Okay, so our program, which is actually in service today with Jeff, our firefighter, and Leanne, our co-responder partner, is just spooling up. We were successful in getting a grant for the startup of our Fire CARES program. And the way that we think that this aligns with the priorities from the Behavioral Health Consortium is, the two primary 911 responders to behavioral health, mental health, substance abuse, and other incidents with people in crisis are law and fire. And law has done a great job over the past decade or so of pivoting and coming up with a spectrum of response to those types of incidents with lead programs or navigator programs. Fire is a little bit behind. Yeah, Tom, you can rub that in a little bit. Where in the past 5 years, we've started to realize that we can also impact those same incidents that we deal with and the recidivism that is part of that equation with a model similar to our program and others in the region. So that's how we think Fire CARES is going to be impactful in the in the goals cited by Behavioral Health Consortium. Gabby, do you have anything to add to that?
Sure. So we'll be able to increase naloxone access and training as well. My staff and I are all able to provide naloxone training for anybody. We do carry naloxone with us. We do work very closely with Anya to make that happen for people. We also improve screening for SUD and OUD. We provide referrals to providers, harm reduction, early intervention, treatment, and support services for people. We regularly refer people to providers to help with other issues, infectious implications, things like that. We reduce treatment barriers by meeting people in the field and where they're at. We also improve screening for SUD and OUD. We can provide referrals to providers, harm reduction, early intervention, treatment, and support services. My staff is able to provide field-based chemical dependency assessments as well. So we're able to meet people where they're at and get them the services that they need, which enables individuals, families, caregivers to find access and navigate treatment for those services, as well as home and community-based services and social supports. And that's in the recovery thing too, so I'm not going to read that again, but we do all of those things.
Okay, so I guess are we going to have Lisa go through the slide deck, or do you want me to share my slide deck, or how do you want to work this?
I think Lori incorporated your slides into these and she's going to run them for you. So you just need to tell her when to advance them.
Great. Okay, well, the first thing is I've been doing a lot of these presentations. I want everyone to feel like I'm accessible. So please feel free to reach out to me with an email, and the same with Gabby. I know Gabby's really accessible too. Next slide, please. What CARES stands for is, Community Assistant Referral and Education Services. So we're in the, call environment that I described a minute ago. We're basically instead of the fire engine or ambulance being the ones that are, trying to direct resources, our CARES unit is the one that would follow up and direct the customer to the right resources in an expeditious manner. Next slide. The primary goals to the program are to refer people to the appropriate resources earlier in the chain of recidivism and to reduce the low acuity calls for 911 that we experience, and I know law experiences as well. So this is our, effort to mirror what law enforcement deals with for the non-law enforcement calls that involve mental health, behavioral health, other crisis-related issues, and the follow-up that needs to happen in a very structured manner. We aren't necessarily the ones that are going to be dealing with the referral entirely, and Gabby, feel free to jump in, but the interplay between the two co-responders, the firefighter and the co-responder from Gabby's organization, will complement each other, and there'll be elements of one contact with one person that each of them is more expertise in solving, and that's how the model that we chose was Paulsbo's program, because it's really the right size program or the bite size program for us to start on. I have every confidence that by the the way the program exists today is probably going to evolve over time as we become more adept to what resources are available and how to solve the issues that we encounter. And the most recent one is actually happening right now. We had an elderly gentleman drive to one of our fire stations over the weekend, and we've since contacted him 3 times, I believe, for subsequent issues where he's waiting for shoulder surgery, but he lives by himself. He was confused when I interacted with him the second time he called for help. And really, he needs someone to check on him, make sure he's taking his meds, that his doctor knows that he's having some, issues with his home medical device. And that's where the CARES program comes in. He's also a veteran, so he wouldn't normally have access to our local EMS, or I'm sorry, urgent care or Jefferson healthcare per se. So that's one of the incidents that Jeff and his partner are already dealing with. And those are the kind of things that normally we would just keep sending an engine every time he calls for help. And that's not a good use of resources for us. Our call volume has exponentially grown, which we'll talk about later, but this program is meant to deal with that in our environment. Next slide, please.
So I just want to let you know that you're halfway through. You have 5 minutes left.
I'll talk faster. So I am going to breeze through this, but I did talk about this slide earlier, or this topic earlier. These are the main things that our CARES unit is going to be dealing with in the field. Next slide. And then I talked about this as well, the difference between the real team, the difference between law enforcement navigators and their strong work, and then the CARES team, which is just another tool for us to deal with the needs in our community. We're the oldest population in the state also, and our CARES people are also very adept at dealing with the unique challenges of that paradigm, which I think is one of the reasons a lot of people live here, is you can live a nice, healthy, safe life here in Jefferson County, but we need programs like the Real Team and the Navigators and CARES units to point us to the resources. Next slide, please. Why now? Well, I talked about this a second ago, where our call volumes increased by 50% since 2011, but our people has not. More than a third of the time, our 911 calls are happening stacked together, and EMS calls are about 75% of our incidences. Next slide. This is our CARES unit. You'll see it parked at Station 31 in Port Ludlow at the beginning and end of the day, but you'll see it driving all over the eastern side of the county. It'll be outside of District 1. It'll also service Districts 2, 4, and 5. Next slide. Like I mentioned, we use Paul's Bow's program just because it was so easy and supportive with their leadership to modestly adopt it and put it into our system. But we're also part of the statewide CROA Alliance, which has been a great resource to learn what other larger, more well-funded programs are doing. Next slide. Again, just a nice screenshot of Gabby and firefighter Dave and the great people over in Paul's Bow. Next slide. The policies are actually being updated right now or adapted from Paul's Bow. We're about halfway through. I suspect by Monday or Tuesday, we'll have final versions that have our branding on them and have been adopted. But we also have a committee that Commissioner Tillman is on, Gabby is on, and our medical services officer as well. Next slide.
So 2 minutes, just let me know. It's an unfortunate job I have.
Nope, you're doing great, Lisa. Thank you. Specialized training, which was one of the questions we talked about. This is collectively, they just finished crisis intervention yesterday, but we have more training planned for them, but they're both very qualified individuals and working within their current scope. Next slide. The management structure or supervision structure is on this slide. The overall program is, for now, supervised by me with the help of the CARES committee. And then the daily management structure is they're going to report to the battalion chiefs to comply with our rules and regulations regarding accountability. Next slide. The CARES, by very definition, the CARES crew is interacting with all of our agency partners. So they're going to be reaching out to all of you probably within the next couple of weeks, trying to build relationships and trust. Next slide. We're going to crawl, walk, run, and know what we don't know. And like I said earlier, I'm sure the program is going to adapt several times over its the next 6 months. Next slide. Please feel free to email me with any of your questions. Next slide. And that was the end of my presentation. I don't know what this is.
Great timing. I was just going to say time is up. So perfect. Thank you so much, Chief Black and your CARES team. So now we have an opportunity for everybody that's at the table to see if you have any further questions. Like I said, I'm going to go round robin. I'm going to just call on people as I see them on my screen. And if you want to pass, pass. If you have another question, please ask it. We have 15 minutes for this. Colleen, you're first.
I don't know that I have a lot of, I'm just curious about like documentation. Is there documentation out for patients like this? And is there a way to let the primary care providers know that, you know, I know like when you're dealing with EMS, EMS will sometimes call, and I'll use the fall program as an example. EMS lets them know. So there's like kind of like that HIPAA compliance and everything else. And so there's a lot of difference with behavioral health and everything else. But if you have patients, and I would hope this would overlap to the falls, and that not just behavioral health, but those vulnerable populations that are out there, and how we can help each other, and how that documentation goes, and how your team is going to be able to, like, hey, I've got this person that we keep going out, and maybe they don't have any food, they don't have anything, that kind of the medics do now. How is that going to be? Is that worked out? Does Paul's Bow do that now? I don't know.
We do. We have individuals sign a release of information so that we are able to contact their either primary care doctor, mental health professional, their substance use disorder professional, Fish Line, which is like Kitsap's version of OLICAP, food banks. We have them sign releases for all of those things that they want us to have access to. And then they identify what areas of their information we can share with other partners. If they don't want us to share information, then we don't. If they do, then we have them sign a release, and then we send a copy of that release to the individual that they've signed the release for, so that you guys have a copy of that as well. And then we start making those phone calls. So you'll always get a copy of the release of information before they actually start asking you questions or telling you information. You'll have that copy of the release of information. As far as documentation goes, if we need to send you documentation about a certain individual, then we send it however everybody's different, whether they want it by fax, email. If you guys have different portals that you want us to send things to, everybody's different. And that's kind of part of the collaboration that will be happening in the next couple of weeks, with the team reaching out to all of you guys and asking how you guys want that information relayed to you.
Perfect. And will that be East Jeffs, or will that be Believe in Recovery?
The team has East Jefferson email addresses. And so I think our firefighter,
Gabby,
Jeff, is here.
I'm going to have to cut you
Okay,
off.
sorry, I'm done.
So we can get around. And Lori is recording this, so I'm going to make sure that everybody has an opportunity to ask a question. And if we don't get the answer real time, we'll ask the teams to follow up. And as a reminder, you're welcome to ask Anya questions as well. So Dr. Carlbaum, sorry.
I guess I don't have questions for Anya, other than just thinking about how to measure the data, and I think she presented that well. And then I guess for the CARES team, I guess, Gabby, I've had 2 meetings with you, and Brett, one with you since the last BHC meeting, and on both those meetings focus was really on sort of prioritizing of patients' suicidal ideation and suicide attempts, and mental health and behavioral health. And I guess one of my frustrations is that the right focus? And so I appreciate hearing for the first time today that the program will evolve as needs are assessed. So that's great news. I still haven't seen any policy or memorandum of understanding, and there's still a lack of clarity about documentation requirements. And I guess I guess I was wondering if I could engage, maybe Dunya could go next, because I do believe there was doing a little historical research as the new guy, I'll use Chief Black's phrase, a symposium in 2019 in our community where many members of the community met and discussed community paramedicine or mobile integrated healthcare and how to support elders with our aging population to stay in their homes. And it seemed like my understanding of that was really focusing around elders staying in their homes and what that meant. And there's a lot of programs built for that. And I guess I'm just not hearing that. So I'm still having a hard time teasing apart how Fire Cares will be different from the real team, for example. They sort of seem very overlapped to me.
I think there's a lot there in that question / statement and the previous ones as well. And it might be helpful if we can maybe chunk it up a little bit, just so we can be more concise. So I don't know where to chip away first, because that's you have a lot there. Doc, I would really appreciate it if you maybe reach out and we could connect offline too, because I think there's some other conversations happening in the background to clarify the goals of the program. But the primary goal is to reduce the impact of 911 resources. That's the number one goal of the program. At the same time, the parallel goal is to get people referred to the right instant or the right resources as early as possible. And Jeff, maybe you feel like you want to add to maybe what how you're going to apply some of those things.
So let's hold up, and like you just said, I think that's a great idea to chunk up the responses. So keep these in mind, and going to continue to go around. So because people might have similar questions. Thank you.
Okay. The next part or the next question or the chunk. I think you asked about agreements. We've already got all the agreements in place that we need. So we appropriated a lot of the great work that Paulsbo did and Believe in Recovery, and have gotten all of those signed already through our legal department. So those are already in place. The record keeping has already been worked out. The policies, as I mentioned in my presentation, are in draft form, and we'll have those ready to go next week. And the CARES committee is working on those.
Thank you. So Dr. Karlbaum, you suggested that we invite Dunya to go next?
Yes, I'm happy to go next. Thanks so much, Dr. Karlbaum and Lisa Ray. And thanks to all three of you for your presentations. This was helpful. I had a similar question to what Dr. Karlbaum was getting at. I'm a huge proponent of community paramedicine. Jefferson Healthcare has been for a very long time, as a great program that we should definitely implement here in the community. But I am also having a hard time understanding the focus of this. In the last presentation, there was a targeted impact where it was 760 some odd calls were related to falls. But I didn't hear that again in this presentation. And I do think that some of the linkages that we're going to need to the community partners that are going to be critical for this to be successful depends on sort of where that targeted impact is going to be focused on. And so awesome that it started today. Start to reach out in the next couple of weeks makes me a little bit nervous. So what are your plans for sort of fast tracking to make sure, since this program is already going, how are we going to make sure that the right connections are being made and people are getting into where they need to be and the community partners feel included, and we have a really successful program at the end of this?
Yeah, I think that's a good question. And, you know, first of all, we already have a falls program in place. So I'm really glad you mentioned that. And that is part of the data in the needs analysis that we put together. We had that slide in the slide deck, but it got cut due to length. So that's still one of the priorities, is to try to refer people as appropriate to the right resources. Dunya, to your program, you know, our firefighters are already aware of how to refer people for a falls type need. So, I mean, that's not new. What I talked about, you know, building our policies over the next week or so, some of the other awarenesses and connections with resources is what we're talking about. So we already kind of have, because Jeff and our co-responder partner are already experienced in this working environment, a lot of those relationships are already initially established. So they're going to just build on all of that and then be able to refer, as we do to a certain degree already, but just expand that capacity. That's really the intent. So we'll still do falls referrals as we do now, and probably better. We'll still do, you know, referrals as needed to, you know, the Discovery Behavioral Health. We'll do referrals for mental health and crisis intervention, and probably some for housing, some for financial needs, some, you know, more than what we've done before. And that's really the gap that we already deal with the fire engines and ambulances. So this is just to take that place.
Thank you. Jim Novelli.
I'm unmuted. I couldn't find it, couldn't see it. So my question is, today was the first time I heard more about paramedicine, working with people that are shut in and can't get access maybe to healthcare, or like the shoulder issue or falls. But I'm really concerned why this team is going to have a mental health professional and or an SUD professional and dealing with crisis intervention. And we talk about rapid response. And when somebody's suicidal or in crisis or psychotic, we have a team that goes out and do that already, and time can be of the essence. So my question is, who's, you know, I'm concerned about that evaluation, where that's going to take place, and is duplicative of what's really available already, and the role that we play as having the DCRs, designated crisis responders, who are only the authorized people to actually perform ITA services.
Yeah, this
so-
is definitely not meant to duplicate services, Jim. And I think at our last meeting, I think there was some latching on to that, just because that's one of the trainings that some of their credentials that the co-responder partner has, but that's not the primary focus. And I'm going to kind of punt it to Gabby to maybe give the reality of how this is, that skill set is applied.
Yeah, and we'll need you to be brief, Gabby, so we can keep going around this.
Absolutely. We are not doing any ITAs. That's still, if we are interacting with somebody who meets criteria or is displaying concerning symptomology, we do call the VOA pretty consistently. We are following up with people. So we're not a first responder, we're a second responder. So we're following up on somebody that had these suicide ideations over the weekend, and we're making sure that they have the resources and the information for 988 and the information for the VOA, and their family has that information. In case something like that happens again, we're following up. We're not responding and saying you need to be ITA'd or you're being held under this. That's not what this is.
So just to follow up, so when a call comes in to 911 and somebody says, we have an individual, I think my daughter's suicidal or she's having psychosis, who responds? How's that going to be handled?
We're not a dispatchable unit, so we wouldn't be the first responder on that unit.
Yeah,
so however that call gets
response.
handled is how that call gets handled, and we follow up.
Yep.
Thank you. So I'm going to move
That's
now
fine.
to Jolene.
I had a question around services versus coordination, working here in Kitsap County related to CARES. And I hear, Gabby, a lot of your conversation around all of these professionals that are going to be accessed by this team. And it's my understanding that CARES is a referral and education and resource-based program. So just want some clarification on that. One, and coordination with the crisis team is a big priority for us, as we've seen some challenges here in Kitsap related to that. And then my third question is about staff roles. Most of the programs have independently licensed social workers, and your structure looks a little bit different. And so I wondered about the credentials of the staff who are going to be engaging on this team.
Sure. So we have a mental health professional that has served as a DCR for quite some time. She has experience. She has vast experience. I'm not going to go over her entire resume right now because we do only have 12 minutes left in this meeting. But she is a mental health professional, and she will be the primary co-responder on this team. We do have also an SUDP that will be going out as well. As far as referrals, is your question about referrals, how we make those referrals, or whether or not they're...
Well, I know the other CARES teams have been very clear they don't provide services. They provide coordination towards services. But if the staff responding related to your team are those credentialed staff, that's kind of where I was unclear.
This is not a clinical role. So that's number one. This isn't clinical. It's not clinical in Pulsebo as well, or CK. We just expanded to CK. So we're not a clinical role. We do provide coordination of services. So there's a lot of like, oh, you need a wheelchair. Let's figure out how we get this. You need a transfer pole in your house. Let's figure out how we can get this for you. Or do you need a referral to your primary care doctor? Like you haven't been going to your appointments. We make those referrals, and then we help them make those phone calls, or we make them for them if they're unable to do so.
Thank you. Commissioner Brotherton, did you have any questions?
Great conversation, but I'll pass. I'll defer to the professionals here.
Brian, did you have any questions? Okay to pass.
Not for now, thank you.
See, people are jumping around. Cherish.
So mine is a logistics question, and I apologize for missing December. I had a horrible case of tonsillitis. One request is for 25,000, one's for 46,000. What is the available monies, and for how long are each of those grants? Lori, answer that one, I think.
Yes, sorry, had to find the mute button. I'm never on mute, so it's like a new thing for me to find it. So the grant we have in excess of the whatever the total of 46 and 25 is. I would say maybe there's 100,000 that we're looking at, and possibly more. We need to remember that this grant goes through August of 2023, so we're trying to get the funding out there and on the streets so that it can be used by the end of the grant here, 8 months hence. So did I answer all of your questions, Cherish?
Yes.
Yeah, so yeah, we're not trying to, it's not really, I mean, there's enough to potentially fund both, and both of the requests. You know, I would say, you know, one component, you know, for anyone that's doing some of the street outreach stuff, you know, I would like to see some more cleanup money involved, for the people who are encamped. We've got to put, you know, some money towards, you know, if you guys are bringing stuff out to these folks, some stuff's got to come back out. This is just getting to be, you know, too much to handle. And I think that's a portion of dealing with some of the advocates and dealing with some of the volunteers, is also helping with ensuring that we're not just collecting the needles. Let's also collect some of the other trash or bad tents or sleeping bags, stuff that's been left behind. So it's hard for me when I see supplies, right? Because I go out, I see this stuff. And so, so I'd like to see, you know, some dollars go there too.
Thank you, Cherish. So the February meeting is going to be a really great place for you to bring that up again. So thank you. Richard, did you have any questions?
No, thank you.
Denise?
No, I don't. Thank you.
Cassidy? Did you have
I don't have any questions for now. Thank you.
Is Apple still here? People are jumping around on me.
I'm here.
Okay, did you have any questions, Apple?
Thanks, Cecil Ray. I just want to express my appreciation for the clarifications. Thank you, Gabby and Chief Black. My only question out of curiosity is, how do you wrap up a client? So I understand the following up, that's really important. And I wonder how follow-up ends. Is there a magic way to know when that is? Is there an algorithm or some sort of meeting criteria for that particular episode that then helps you close it? Because that's a sweet spot for sure.
Everybody's different.
Answer that in the chat. That would be great. Thank you. Oh, we can come back if we have time. Time is ticking by. Patrick, did you have any questions?
Not in particular, but I support both of these programs, and I'll just share a very quick anecdote. A long time ago, I was involved with this sort of work in another state, and there was a sage there, and duplication always seems to come up. And he said, perhaps the only time you have duplication is when two people are trying to do the same thing with the same person at the same time, and all the coordination that is going on here, I think, is going to sort that out. Just a reminder, it's great to refer people. It's great to be out there when you need to be out there, but where are we going to put them? The other side of this is a shortage of places for people to go. In many cases, housing, obviously, we're all painfully aware of that. And so anything that we can continue to do to address the other side of this, I think, is extremely important. But I support both these programs and really appreciate the good work that everybody's doing.
Thank you. And hold that thought for the February meeting. Tom or Thomas, sorry, I don't know which to call you. Did you have any questions?
I have a question for Anya about the kits and how many of those have been handed out up to this point, and do we have any data on their use and the success of that?
Hi, I've distributed 350 kits since April last year. And part of the DOH program is that when I distribute, I ask people if they've used them before. I haven't had a direct feedback from someone that they've used a kit that I've distributed. A lot of times when I'm distributing, I'm meeting people that I've never spoken with before because I'm at different types of events. So I don't have specific data on knowing what percentage of those have been used. But in the slides, there is a link to a research study that was done in North Carolina that shows that for every 100 kits given out, the percentage of the less overdoses that are showing up in that specific county. So I can look to other communities that have similar overdose and naloxone education programs to estimate some of that data, but I don't have specific data to know exactly how many kits have been used. I hope over the next until August that I might get more feedback from people that I've met. But since this is a new program, I don't have that data yet.
Thank you. Jeff, did you have any questions?
I do not.
Thank you. Barb, did you have any questions?
I will pass for now, thanks.
Kelly?
I have no questions at this time. I just want to thank both programs.
Okay. Deborah.
So no questions at this time. Thank you for offering.
And Adam.
Hi, yes, I actually do kind of want to piggyback on Dunya's comment in the chat. I just want to know, is there going to be, kind of phrasing what she said, a level of rigor, like a data backbone on this, and is there going to be a plan for kind of evolving the program based on the data as you go along, or is there how much planning is there with leveraging the data as it comes in? And
are you talking about data for Anya's proposal or the CARES proposal? I'm sorry, I can't see the chat.
So for the naloxone distribution or the harm reduction program, or for the CARES program, or which were you referring to?
I'm sorry, this is for the CARES.
Yeah, we're required to do reporting monthly for the Association of Washington Cities, who is the grant funder. And that so every month when we have a whole bunch of data that we're collecting for every contact, demographic information that we submit in our monthly report, along with the status of our program and lessons learned, or know what we don't know, if you prefer that term. And that's going to be, once the grant performance period with the Association of Washington Cities is done at July 1, we're going to continue that same reporting process monthly, where the potentially behavioral health grant will kick in. And so we'll be happy to share that same data with the committee, and we could share, everything we do is public record, so we could share those reports starting with January's if desired to BHC, just so they can kind of see how it started and how it's evolving and how we progress as we go through. I think that's a really healthy process, and that's one of the goals of the committee that we put together as well.
Thank you so much. So I know we just have a couple minutes. Dr. Carlbaum, did you have your hand raised and I missed that?
I just put a comment in the chat regarding Chief Olson's question.
I'll read it out loud for people that can't see the chat.
Oh, I'm happy. I can read it. I'm happy to do it. Chief Olson, I just want to add that on several occasions, responding EMS teams have been dispatched to a cardiac arrest for a presumed cardiac arrest, and it's an apneic patient who's received citizen naloxone. Unfortunately, the teams, because they're caring for the patient, frankly, don't ask where the citizens got their naloxone, so we don't know for sure. And then also, if you look at the National EMS Opioid Overdose website, which is a new data stream that comes from EMS data, both Jefferson County and Clallam County were very high above the national average for non-fatal opioid overdoses a year ago, and now Jefferson County is below the national average, where Clallam County remains above. So I don't know, maybe that just means there's less fentanyl trafficking because of the great work of your officers. Maybe that means people are getting smarter and using fentanyl test strips and avoiding it. Or maybe that means there's more naloxone. I don't know if we'll have granular data because of the challenge of some people who choose to use substances and their reluctance to give a lot of personal information.
Thank you. Okay, I know we're at time. We could have spent 3 hours with each other talking about all of this. I really, 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 or we really appreciate all of the work that you're all doing. Thank you to the CARES team and to Anya for responding to the questions that the consortium submitted and for all of your questions and comments today. Lori, you're going to send out a link for people to vote.
Yes, I'll be sending out a link to the voting members so that you can vote. And then just quickly, I'd like to say, have a look at the rest of the slides in your packet. There's an overview of what we're going to be talking about at our next meeting, a link where you might actually help seed that conversation, and then an overview of legislative bills that are in play right now that might be interesting to the folks at this table. Lisa, did you have anything you'd like to say?
Is there time for one more quick question? You know, I always am trying to sort out this stuff, and I'm new to behavioral health. Gabby, I just want to ask, because I hear a lot in our 2 meetings we've had about providing mental health services. I know in Quilcene, the Quilcene Fire Department has told me they're referring patients to you for mental health care. Is Believe in Recovery licensed to provide mental health care in Jefferson County?
Nobody's referring people to us for mental health care, especially in Quilcene. People don't come in for mental health services. We are in the process. So stay tuned.
So not okay, thank you.
But no, we're not providing mental health services. And this, again, is not a clinical role.
Well, thank you all so much, and look to hear from Lori to provide the next round of voting, or the first round of voting. Happy New Year to everybody, and thank you for your very thoughtful conversation today. I'm so impressed with the work you do in service to Jefferson County.
Just real quick, Anya, good luck with your application.
Thank you.
And thanks so much to Lisa Ray Thomas for facilitating this conversation today. Bye-bye.
Bye. Thanks, everyone.
Bye.